everyone to another question day. So today we'll be talking about cardiology question. So a 35-year-old male patient presented with chest pain that is exacerbated by inspiration. So it's an inspiratory chest pain. The pain is relieved with leaning forward. So with leaning forward, it kind of relieves. ECG is normal. Echo shows mild pericardial effusion. BUN is high. Creatinine is also high. Which of the following is associated with this disorder? So first of all, we need to kind of know what this disorder is. What is the diagnosis? So the diagnosis here is pericarditis. Pericarditis. So remember here I said ECG is normal, so that is gonna be. This is why I put it in the question, just so you know that this is a uremic pericarditis case. So in uremic pericarditis, ECG changes are usually not seen. ECG changes are not seen. So that's one thing you should be aware of. And the reason for this is because the myocardial inflammation is not present in uremic pericarditis. And another thing to be aware of is when uremic pericarditis usually occurs, BUN is greater than 60. So that's another thing. And so far we know that it's pericarditis. It is uremic pericarditis case. ECG is usually normal. So what is the management for this? The management for uremic pericarditis is urgent dialysis. It's a really strong indication for urgent dialysis. So dialysis should be done. So remember, for different pericarditis, we have different management. So if let's say we have pericarditis, and we have, let's say, after MI, post MI, then we are going to look at if it is peri-infarction. Peri-infarction, remember, occurred days after MI. Then in that case, you give aspirin. Remember, do not give other NSAIDs. Do not give other NSAIDs. And so the reason for this is because if other NSAIDs are given just after MI, like days after MI pericarditis, then that actually impairs healing and scar formation. So there is increased risk of rupture of that myocardial wall because it's weak. If there is no scar formation due to NSAID use, then there will be then the scar will be weak, and there is increased risk of wall rupture. So then we have another type of pericarditis after MI, and that is Dressler syndrome, and now it is also called post myocardial injury syndrome, and that is because of the formation of antibodies. So it will take time, like it will take about weeks to form antibodies, so about 1 to 4 weeks. So against the pericardium, antibodies are formed. So in this case, you can just have the typical management for pericarditis, like you can give NSAIDs. Remember, for the first episode, give NSAID plus colchicine. And then if it is resistant, then you give steroids. So that is about the post-MI pericarditis. Then the most common cause is actually idiopathic or viral. And for that, the management is similar. You give NSAID and colchicine, and it is non-responsive to steroids. Another one is this pericarditis, this uremic pericarditis. For that, you do dialysis. So this is the entire management. So if someone says, what is the treatment for pericarditis? You can say it depends on the etiology. So that's important to know. It's not just directly NSAIDs and colchicine. We have to know the etiology. For peri-infarction, remember aspirin. Avoid other aspirin. This is a really high yield point. So, all right. So now we know that this is pericarditis. We know now the management of pericarditis. But let's talk about the other about the option. Which option is right? So postoperative oxygen is wrong. This will be wrong because this is seen in anything. Let's say if this is the heart, if you have the heart and outside the heart is the pericardium, anything that increases pressure inside the pericardium or increases pressure on the heart from outside, it can cause the right ventricle and the left ventricle and all the chambers actually to kind of get compressed, so that a right ventricle and left ventricle actually compete with each other to kind of fill with blood. So the right ventricle has low pressure, so it will be more compressed. But let's say this is systolic blood pressure. So let's say when you inspire in these conditions where there is increased pressure on the heart, for example, a cardiac tamponade, Cardiac tamponade, for example, COPD, asthma, they also compress because there is a lot of air there. These are obstructive airway diseases. So let's say in those cases there is increased pressure on the ventricles, on the atria of the heart, and when you inspire, because there is increased intrathoracic pressure, there is increased inflow towards the right ventricle. This will actually push this septum, interventricular septum, towards the left ventricle side, and actually this will decrease the end diastolic volume here, because now there is less space for the blood in the left ventricle. So the left ventricle end diastolic volume will be low, and that actually decreases the systolic pressure. So if the systolic blood pressure drops by greater than 10 mmHg, that's pulsus paradoxus. Normally it does drop, but it is less than 10 mmHg. So remember, severe asthma, COPD, and cardiac tamponade. Cosmal sign. So the cosmal sign is another one that is seen in constrictive pericarditis. Normally when you inspire, if this is JVP, let's say if this is the heart, this is the right atrium, and this is the JVP. So normally when you inspire, blood will come down into the right atrium, it will fill the right atrium, and the JVP drops, right? Because there is not a lot of blood here. But let's say you have constrictive pericarditis. Here we have constriction. There is the right atrium is not able to kind of relax or fill with blood easily because there is constriction or fibrosis from outside. So here, when you inspire, blood cannot come here because there is it cannot expand the right atrium, and so the blood is going to stay there. So there is no drop of JVP with inspiration. It's just it's unchanged. It's neither increase or decrease. So that's also wrong. This is seen in constrictive pericarditis. Then scratchy sound on auscultation, that is the right answer. In pericarditis, you do see the scratchy sound. Remember, this is a triphasic sound. One is the systolic, then one is the early diastolic, and other one is the late diastolic. Hepatojugular reflux is also wrong answer, and this is seen in anything that causes anything that causes right ventricular failure. So if there is right ventricular failure, JVP is elevated, and when you push on the liver, it actually increases JVP. So that's that will be right ventricular failure. And I do have a video on hepatojugular reflux. If you want to see, it will be somewhere in my channel. You can easily find it. So I hope this video is helpful and you understood the pericarditis. And if this video is helpful, please like and subscribe to the channel.